So welcome everybody for joining our first CRSU webinar. I can see there are still people joining. The numbers are clicking up, so but I'll just make a gentle start. My name is Olivia Wu. I am the director of the NIHR Complex Review Support Unit. I want to welcome you all to the CRSU's first webinar, and this is a webinar on living systematic review, opportunities and challenges. And it's absolutely fantastic to see so many of you taking time out to join us today. I hope you're going to enjoy our 90 minutes of program today, and I really look forward to some lively discussions as well. It's just a couple of housekeeping points. So first of all, during the webinar, all attendees are muted, but we want to encourage you to submit questions and comments anytime throughout the webinar to us using the questions and answer function on Zoom. We'll try and address some of these questions throughout, but we also have a planned Q&A session at the very end of this webinar. So hopefully that's when we're going to have some lively discussions across the panel based on the questions that you have submitted. This webinar is being recorded. It will be available on our website after this event, including all the slides that are being presented today. So today we're talking about living systematic reviews. Keeping systematic reviews up to date has been an ongoing challenge for all reviewers. And in 2014, Julian Elliott and colleagues published a paper in PLOS Medicine and proposed the concept of living systematic review as a new approach to updating systematic reviews. But it is not until quite recently when we see a growing interest in adopting this approach. So our webinar aims to talk about various aspects of living systematic reviews. So we have 3 sessions. In the first session, we're going to talk about what are living systematic reviews. Is it simply about updating reviews? I mean, we've all been updating our systematic reviews anyway. So is this just another marketing phrase? Is this different to what we're already doing? And is there a place for living systematic review in the context of Cochrane reviews? And in the second session, we're going to talk about the potential challenges in conducting these living systematic reviews. If it's worth doing, then what should we be looking out for? What are the difficulties in doing these reviews? And then in the final session, we'll talk about how will living systematic review change the way we produce and synthesize evidence. So hopefully you enjoy what we've planned for you, and do please interact with us through the Q&A function. So I'm not going to go any further. I'm going to introduce our speakers for the first session. So the first session is living systematic reviews, opportunities, and also how living systematic review can work within Cochrane. Our first speaker is Terry Quinn, who's part of our Complex Review Support Unit. Terry is also joint coordinating editor of the Cochrane Dementia and Cognitive Impairment Group. And then after Terry's talk, Toby Lasserson, who's the Deputy Editor-in-Chief of the Cochrane Library, will also talk about living systematic reviews in the context of Cochrane. So I'll hand you over to Toby.
Thanks, Olivia, and thanks everyone for joining us this afternoon. I'm Terry Quinn, as Olivia said. I'm part of NIHR CRSU. I'm also the coordinating editor of Cochrane Dementia, and I'm based up in Glasgow. And although I've been using Zoom for months now, I still don't always get it right. Can I just check, are people seeing PowerPoint slide view or the presenter view at the moment? If someone could just chip in and tell me. I'm seeing a thumbs up, so I'm going to take that as a positive. So my remit is really to give you a bit of a primer and introduce some of the concepts. I make no apologies for my talk having more questions than it has answers, but really the purpose of my talk is to plant some seeds of things that we're going to develop over the remainder of the next 90 minutes, and maybe already get you thinking about some of the things that we might want to cover when we come to the discussion. On first slide, you're always meant to say your conflicts of interest and your disclosures. So my big disclosure here is I've never done a living systematic review in my life. I think on that hierarchy of expertise, I'm very much enthusiastic amateur rather than an expert. However, I do know experts. Now let me just see if I can change my slide. And I'm very thankful to Annalise Sinnott from Cochrane, Australia, who shared lots of great materials with me based on some work that she did with Project Transform a few years ago, where they tried to incorporate the LSR paradigm into Cochrane. So all the nice slides are from Annalise, all the messy slides are from me. So here's a bit of context. And these are data that won't be a surprise to anyone on this webinar, but it's sometimes just worth reminding ourselves about these things. There's lots of research happening all the time. It's estimated that there's maybe about 75 trials produced a day. I don't know what the equivalent number is for systematic reviews, but I can tell by the number of peer review requests I get, it's not one. So there's lots of original evidence, there's lots of systematic reviews happening. And systematic reviews take a long time, estimated to be about 20 months, probably a bit longer for a Cochrane review. And also takes a long time for new original research to make it into reviews. The estimate there is about 3, 4, 5, maybe more years before a relevant review gets incorporated into a systematic review. And as a result, reviews become obsolete really quickly. So after all of the work that you put in to produce your wonderful review, it's only got a shelf life of about 5 years, and then it's obsolete because new data have came out and conclusions have changed. So that's the context we're working in, and that's very much the context that got people thinking about new ways of looking at evidence and trying to create something that was more dynamic and reactive and, dare I say, living. So based on that, various people were playing around with the idea of living systematic reviews, but this is really the first paper where the term was used. You'll recognize many of the people on the author list here. And this was really the beginning of LSR as we know it, and LSR as it's began to be incorporated into Cochrane. And here's the definition that they used in that paper. They say that an LSR should be a systematic review, and it's all about continuous updating, continuous surveillance, and being reactive to new data coming along. Here is the definition that's used by Cochrane. A bit more succinct, but those same concepts there. So our living systematic review has to be, surprise, surprise, a systematic review. It has to be continually updated. It has to incorporate new evidence as that evidence becomes available. And I thought we'd maybe pause there and just dissect some of that a little bit, because as you begin to think about that definition, you can see some of the potential challenges. So first of all, we're saying that the living review has to be a systematic review. What do we mean by that? Would we allow for rapid reviews? Would we allow for scoping reviews? Do we need to have all the other bells and whistles that go with a full systematic review? And what are we going to include in this systematic review? Most living systematic reviews so far have been of interventions, mostly drugs, but what about other research methods? Can we have a living qualitative review or a living test accuracy review? An area where there's loads of research coming out at the moment is on biomarkers. Should we have living prognostic reviews? And if we're calling this a systematic review, does that mean we're using exactly the same methods as we would in a standard systematic review? Or do we have to have bespoke methods because of the livingness of this thing? And what about this concept of things being continually updated? What do we mean by that? How frequent is continual updating? And we need to remember that it's not just about the updating. When you update, you then have to search the titles, and then you might find papers that need data extraction and risk of bias, and it all needs to be incorporated into a grade. So there's actually a lot of work there. When you take on a Cochrane review, there's a bit of an expectation that you're going to update it anyway. So where does the frequency change where something becomes just a standard updated Cochrane review and a living review? And if you're going to be updating a lot, if you're going to be updating every month, is each review that you produce a standalone data source? Because that means you're doing 12 reviews a year, which seems a bit excessive. So these are all things that we're going to talk about over the next 90 minutes. Now, how about this concept of incorporating new evidence? Well, there's two things there that are challenging. First of all, how do we incorporate it? Do we just plug it in and then run the meta-analysis again? Well, that's a loaded question, and we're going to explain why you need to be cautious about doing that. But also, what do we mean by new evidence? What if new data come out on a trial that's already included? Does that need an update? And what about things like the grey literature, and particularly the explosion in preprints? Would they go in? And what if something comes along that completely changes the paradigm? So, for example, in cardiovascular medicine, we may have had a living systematic review of warfarin for preventing stroke in AF, which would have been great until a whole new class of drugs come along, the direct oral anticoagulants, and warfarin becomes obsolete. So can living systematic reviews be reactive enough to cope with that kind of change in how healthcare works? Well, of course, Cochrane have some guidance, and Cochrane have tried to answer some of those questions. Cochrane have their guidance here for production and publication of LSR. And here are some of the things that they say in answer to my questions. They say that an LSR can be of any type of original data. It doesn't just have to be drug trials. They say that you should retain all of those core features that make a Cochrane review, and you need to be explicit in your methods about the things that you're going to change to make this living. They're less explicit about how often you have to search, but the recommendation is you might want to be searching monthly. But that doesn't mean that you have monthly updates of reviews. Every month you update the website to say what's happening, and it's only if you find a paper that changes things that you then have to update the review itself. So if we have a little peek at an existing LSR that's in the Cochrane library, this is looking at interventions to get kids to eat fruit and veg. And you can see at the bottom there's a disclaimer. This is the most up-to-date review that's published, but it's getting updated every month. And if you go into the website, you can see what's happened that month in terms of what new data have been searched for and if anything's been found. So here is the process. Many of the steps look similar to your standard systematic review. It's when we get down to this bit here that things change. And if we just almost sort of magnify that, what you can see is you continually run your search. If you don't find anything, that's fine. If you find new data, you have to decide whether that data could substantially change conclusions. And then that helps you make a decision about whether you integrate right now or whether you integrate later. And things just loop round and loop round and loop round. But I guess another question that we can discuss this afternoon is, when do the loops stop? When have we got enough evidence? And when can the living systematic review be put to bed? So what have Cochrane done in this space? Toby's going to be talking a little bit about what's happened after COVID. I've called this BC, before COVID, because these were the outputs that used living systematic review methodology before the COVID outbreak. And you can see there are a suite of reviews about preventing venous thromboembolism. There's some stuff on respiratory illness, fruit and veg consumption, and there's a couple of protocols as well. So Cochrane have certainly been active in the LSR space, and there are examples already out there of how LSR has been used within Cochrane. So how has this actually worked in the real world? And probably some of the most interesting stuff that Annalise sent me were some of these papers where they spoke to people about their experience of LSR. And here are some of the things that came out from those focus groups and qualitative interviews. The LSR workload is very different. It's not the gargantuan screening tens of thousands of titles that we're used to in Cochrane. It's little bites of work, but they come all the time. So because the workload is different, the workflow has to be different as well. You might need a team, but what you definitely need is project management and someone keeping an oversight of the whole process. Because you're updating every month, and you may or may not be updating the review, the published review itself, the whole process of how you get academic credit, how you recognize authors, and how you publish that is very different for living systematic reviews compared to the reviews that we're used to. And as living systematic reviews in theory can go on forever, the way that you fund that has to be different as well. And I've said different, but actually the feedback from a lot of people that have been involved in this is that it's different and it's difficult. And I don't think we can sugarcoat that. There are some aspects of living systematic review methodology that aren't easy and that we don't have the answers to. And I wouldn't even pretend that by the end of this 90-minute webinar we'll have the answers, but I think it's good to get the discussion going. So, if it's all of that hard work, why do we want to do it at all? Could or should every systematic review be living? Well, I'd say probably not, but there are some criteria that would definitely lend themselves to a living review. Your question has to be important, that's a given, but you also have to not already have the answer. And through a bit of horizon scanning, you have to think there's going to be a lot of new evidence coming along to justify that time and effort of updating things every month. The other thing that they found out from doing their pilots of this in Cochrane is that you have to have the capacity and the resources within your team to take this on, otherwise the whole thing's a non-starter. So that's all that I want to say. My little allusion to living systematic review in Cochrane before COVID is going to segue on to Toby, who's going to talk a little bit about what's been happening more recently. All of these slides are going to be available, and there's some further reading here if you want to look up some of the things that I've been speaking about. So thanks for listening. We're not going to take questions after my talk, and I'm going to stop sharing my screen now and hand over to Toby.
Thank you very much. I hope you can see my screen. If you can't, I think that was a nod from you, Terry. That's good news. It also means you can hear me as well. So, really interesting, Terry. That was good to sort of get a nice primer from you, because you're right. I'm talking about sort of living systematic reviews and the COVID experience, and my conflicts of interest slide is a fairly standard one. I think for most Cochrane employees, I haven't really done anything commercial or anything exciting like that, but I've probably got more intellectual COIs than I have financial ones. So I thought I'd start by actually giving a bit of an overview as to what the review types have been like and the review questions that we've tried to address on COVID actually. And that was partly because I wanted to sort of get a sense for this myself, and you can see hopefully that we've sort of been somewhat pluralist. We've got a selection of reviews that have been done as rapid reviews, so they used abbreviated methods, and last week we published an update of the quarantine review, so that one was done I think within about 2 or 3 months. That was updated alongside a review on universal screening and travel restrictions. Before then, we had a review on video calls, and then looking at things like ash for hand washing, which was commissioned by the World Health Organization, and something on oxygen targets in critically ill patients, and also digital contact tracing, which is obviously quite a topical question. We've got more than 4 living reviews underway. I'm going to talk today about the convalescent plasma review, use that as a bit of a case study to explore some of the issues that Terry touched upon actually. And we've had an update on personal protective equipment, or PPE. And just the other day, there were 3 reviews that were published between the ENT and Oral Health Group, looking at the standard intervention reviews, all empty, but they were looking at antimicrobial mouthwashing, which is a really important question when thinking about sort of routine healthcare services and how to have sort of safer working environments for dentists and other health professionals who'll be working with, well, I guess the mouth and the head and neck more generally. We had a qualitative review come through looking at barriers and facilitators for implementing infection control measures in hospitals, and an overview that came through quite quickly from the gynae group, looking at interventions that were available to treat heavy menstrual bleeding. And there were interventions that were available during pandemics. Again, it's an overview looking at interventions which are implementable outside of a routine clinic office, because of the lack of face-to-face consultations that are available right now. So maybe to partly answer Terry's questions about the type of reviews, we have got 3 diagnostic test accuracy reviews which are being done as living reviews, and they're showing a lot of the challenges that Terry was talking about, not least with regard to the preprints. But thinking more broadly about sort of how good the fit is between what we're living through right now and the circumstances under which we're under which a living systematic review is feasible and desirable. I think so. Terry got very similar criteria from Paul Garner's paper in the BMJ about when to update reviews. I took actually these 3 criteria, which look incredibly similar, from the LSR guidance from Annelies Sinnott, and certainly with going through those 3 criteria, there are a lot of the intervention reviews that I think we might be considering right now. They're all of particular importance to decision makers, because the pandemic is new. All the interventions, the treatments for it are going to be new. So there's unquestionably going to be uncertainty in the existing evidence base. The third question is really interesting. The third point's really interesting because I think what we've seen with the convalescent plasma review, and I know Maarten van Smeden's talking a little bit, hopefully, about the prognosis review that he's involved with. This third criteria, I think, is a really difficult one to make judgments about, and largely around when you're going to update, because as I think we'll go on to see, that's not always exactly straightforward. So the big difference between living and updated reviews, as Terry was showing, is often about how frequently you're looking for and identifying relevant evidence, and then crucially when that evidence is incorporated into the review. And I think one of the first things I really want to say really about how we've been working through our living reviews is that what will trigger an update of a living review now really needs to balance a considerable number of factors which are internal to the review, but also, as we've probably can all attest, some of those factors are external as well, and may depend on how high profile and how interested and how much attention is being thrown at these things by politicians and by the media. So convalescent plasma is one of a number of treatments which are being trialled across the world right now. It's actually harvested from blood which is donated by people who've recovered from a disease, and it's been in practice for about 100 years actually. And the first sort of documented use cases of convalescent plasma go back to the Spanish flu pandemic, which is a nice touchstone for where we are now. In fact, I even came across a meta-analysis that was done a few years ago, looking at some controlled studies from that era, looking at people who got it and didn't get it, showing huge effect sizes, but obviously there were issues with confounding. So I won't dwell too much on that original analysis. But fast forward 100 years, and in April of this year, we got a protocol from the Cochrane Haematology Group, and they wanted to conduct a living systematic review looking at convalescent plasma, and they were aware of some evidence that was emerging largely at that point through case studies, but they were also aware of large trials that were being registered, and we thought it was a really good opportunity to work with them on developing a living review, a protocol, and then a living review, which they've subsequently updated. So they took a hierarchical approach at the outset. This was deliberate. They were always going to start with the non-randomized studies, but as I think as we've seen over time, the eligibility criteria and the methods have changed. So it wasn't just a case of updating that review with new data, with new evidence. It was also a question of, so far it's been a question of periodically stopping, going back to the original question, and making changes, partly in light of not so much in light of new data, it's mainly in the light of our evolving understanding of the disease and its treatment. So the standard of care has changed over time. That's also necessitated the team to go back and look again at some of the analyses that they've done, some of the outcomes that they've looked at, and some of the characteristics of the patients that they've committed to look at with their review. So there are a growing number of randomized trials that have been registered, but actually still only a few have really provided any data, and maybe we shouldn't be too surprised. I think the sort of stopping rules that have been used in relation to a few trials, so up to now, have indicated things like that chloroquine aren't effective, and we have obviously a signal on steroids. But there's nothing that's sort of stopped a trial yet around convalescent plasma, so we haven't quite got the data from them. What I'm showing you now are the three versions of the review. There are two published versions. The version on the left was the first version that came through, and you can see the difference between the included and the ongoing study. So at that point, back in, I think it was June, and we first published this one, we had no RCTs included, but they'd identified at least 22, I think, which were randomized. Fast forward a month or so, and there's probably a sliver which you might not be able to make out at the bottom of that column in the middle two bars there. And that's indication that we had I think we had 2 RCTs included, but they identified about 48 RCTs. So we're still reliant, at least for the 2 published versions, on non-randomized studies. But there's obviously a growing number of RCTs that are being registered and that have been recruiting since the start of the pandemic. And so that last version that you've got, which is currently in our editorial process, you can actually see a drop-off in the number of included studies, and that reflects one of the things I mentioned a little while ago in relation to this review, which is the shift in the eligibility criteria, as they realised that the study designs that they're using, the quality of the studies coming through, I think, is incrementally better. I think they're aware that they can start dropping off some of the case series, which is immense relief to all parties, I think. But obviously, the 78 studies which are ongoing, I think, we're waiting for results from all of them. But the good thing actually about this process is that they've also started to reach out to the study investigators concerned, and they're in quite frequent contact with them as they approach the sifting and incorporation of new evidence in the review. So I might just pause here and show you something that sort of struck quite a chord with me. This was published in Science magazine back in May, which feels like about 2 years ago, but it was only a few months. And it's a really interesting piece on taking a stand against what they've called pandemic research exceptions. And so Alex John London and Jonathan Kimmelman co-wrote this sort of opinion piece. And I felt that the quote that I really took to heart here was around around small studies and the risks that we all run when we sort of embrace and incorporate uncritically studies which are underpowered or maybe unblinded, or they're of lower quality than we would normally accept. The reason why we're rushing to to incorporate this evidence is unquestionably because of a moral imperative around the pandemic. But as they quite nicely argue, the moral imperative actually should be to stick to the standards that you're used to and don't give an inch, because actually it's the risks of reaching unreasonable and unfounded conclusions from the kind of research that we have seen published up to now will vastly outweigh the benefits of doing so, and vastly outweigh the benefits of doing so, and risk all kind of harms, especially when larger trials that we know are out there will deliver their results. So one of the key decision points that the review team for the convalescent plasma review have struggled with a little bit, but with some contact with us and the central team, we've sort of got a few ideas together about what we might do going forward. And I think it comes down to this whole thing about, you know, should you be updating this every few weeks? Because in COVID land, things move incredibly quickly, or at least that's the popular story, right? Everything's moving fast. But in fact, as I think I've shown a little bit, the RCT evidence hasn't really moved forward very quickly. We've got a lot of understanding about the studies that are ongoing. So one of the advantages of sort of coming back to this review every so often is that it helps to really get a sense of where the different studies are, the landmark trials, if you like, that are likely to deliver results that might change practice. They're sufficiently large that they'll be able to do that. So coming back periodically and checking on their status with the study investigators is a really important part of this process. And obviously one of the things that we've also seen with COVID research is trials that have adaptive designs where they don't stop a trial, but they'll stop an arm. So the recovery trial, for example, in the UK has already stopped the chloroquine arm, and also I think stopped recruitment to the steroid arm. But they've continued with other treatment arms in that particular study. One of the things I think is really important to come back to is the 3 Ps. The press going, you know, nuts over anything and tend to latch on to things that provide rays of hope in inverted commas or sort of positive messaging. The other P that's important is preprints. So there's a lot of research is getting shared via social media and also by press release, actually, which is a bit regrettable that you're seeing preprints getting press released, which I don't think is the right thing to do. But that's obviously pushing some studies into the limelight and creating what I'll call study notoriety. So in relation to this particular review, there's a really large, I think, open label extended access program study from the States, which everybody in the convalescent plasma community knows as the Joiner study, so Joiner 2020. Now that's already been published, but the updates of that data set are getting, I think, put onto medRxiv. So that's a really large cohort study. It's about data on about 40,000 patients now. And in the absence of an RCT, that's the sort of the data set that a lot of people are talking about. So we have to keep people's expectations grounded and remind everybody about the limitations of that particular design. And the last P is politicians. Actually, just before the last call that we had with the author team for this particular review, Donald Trump had amplified that decision from the FDA in the States about urgent use of convalescent plasma. So we felt that there was a need to kind of remind people about the limitations in the evidence base because of the hype that could easily surround things like convalescent plasma. I've made the last point already, so I'll just forward on to the learning points that I think I've picked out from all of this. So I had an email exchange with the authors. I was letting them know about this talk I was giving, and I wanted to sort of get what they thought as well, because I've got my own sort of perspective on this, given where I sit in the process. But one of the things that they emphasised was the importance of ensuring that you've got the resources in place to fit with the ambition that you've got around this. And I think in the context of this particular review, this is very much in living mode, this particular review, and the authors are working. There's a large team of them. That's the first thing that's also really important. They're distributing tasks. So the micro tasks that Terry was talking, I don't think they're sort of small, those tasks, and they're not particularly bite-sized. They're sort of continual. So there's a challenge definitely for them around ensuring that they've got everything in place to help with that. Trust and communication within the team. So because of the size and because of the task that they've got, they have to stay in regular contact with each other. And they also have to, there was actually a point I wanted to make also about communication outwardly as well. And that involves us in the sort of the editorial team, so they can flag when they think a submission is going to be coming through. But also that communication with the study investigators that they've been engaged with is really important, a helpful part of helping them plan their updates, potentially getting access to data as well that would otherwise be going into a publication. Technology needs refinement for living processes. Who knew? The team have found, a lot of the teams that have been using Confidence are finding that it's quite a difficult thing to use for their purposes. We also are seeing with the publication system that Cochrane uses that there are certain advantages to being able to publish updates. But even within that, even with that sort of apparent advantage, there are challenges around giving people a heads up around the studies that are awaiting assessment and communicating outwardly about when we think a review is going to be submitted for editorial processing, because obviously these are reviews where keeping users or readers abreast of developments with the process are no less valuable than the finished product. The uncertainty for now, I think, is around the risks and benefits of using preprints. So there's obviously the advantage that you're able to access something really rapidly, pretty much on completion of a manuscript, but nobody knows just how reliable they really are. And a lot of the studies that are being done and are made available as preprints are as bad as the studies that were published before the pandemic. So there isn't necessarily an increase in quality, but there's obviously also the challenge of data which might change between the submission of that, between the uploading of that particular preprint and what might ultimately get published. Choosing the source of evidence according to the breadth of the question. This is something to do with searching and making sure that depending on the condition that you're looking at, of course, that you've got the right the right sources of evidence to search in. And with COVID-19, Cochrane's got its own COVID-19 register, which we're hoping for a number of these, but certainly the convalescent plasma review is enough, but there are other reviews that we're aware of that may be looking at slightly broader questions in critical care medicine more generally, or infection control, where actually you might be going back a little bit further. And that was certainly true of also the contact tracing review, where they looked at studies from previous epidemics. Really important part, I think, is that sort of that moment where you pause between versions of reviews and you build in an opportunity to look again at the question and the methods. Certainly with regard to COVID-19, I think there have been changes in the case definition that the WHO have developed, and I think in the most recent version of the convalescent plasma review that we're working with the authors on planning ahead already for the next one, where they're thinking about different subgroups because of the way that the case definition has changed. Back in April, I don't think that we had a core outcome set as well, and that's something which is sort of a process which is external to the review, and that may yet come and influence the outcomes that end up getting they collect data for, put into summary findings tables, and drive the conclusions through to the abstract and plain language summary. But the other thing I think that's important is that any changes to, and this applies outside LSRs, but I think because of this process, the reassurance that teams need, I think, is around that implementing changes to protocols are fine, but they need to be done in good faith, so have a good reason for doing it. Relate that back to the question or something about the question. So, the core outcome set is a good example, and the case definition there. And to report on these honestly when the review's done. And this is the last slide, I promise. So deciding what parts of the protocol to change and when to update, even when you think you've got a good handle on the changes to the case definition, or you think you've got a good handle on changes in the study quality, and you think that the evidence is improving, I think it can still be a difficult process to work out when to stop collecting data and when to update. So, calling out for help, be that from clinical colleagues, or be that from us centrally, or be that from the Cochrane Review Group. That's a hugely important step to take as well. I don't think it's necessarily things that the author teams should be making entirely in isolation. Lastly, but by no means least, the process I think that I've learned most about in all of this is around the separation between identifying studies, collecting data, and write-up. Because for me, I think what we publish, what Cochrane publishes, or what the BMJ publishes, will always be a sort of a static document. But the process that feeds into it, that gives you the data that you synthesize, that gives you the insights that you're then writing about, that process is continual and it's dynamic. So whilst the study identification and data collection is continual, the write-up isn't. Thank you for your time.
Thank you, Toby, and also Terry. There's clearly quite a lot of value in going down the route of living systematic review, but it seems there's also a big learning curve for all of us. So I'm just going to quickly go to a question that's been posed, asking about confidence, because Toby, you mentioned that that there are challenges to using confidence for living systematic review, and Jamie Hartman-Boyce, she's about to dive into a living systematic review, so she really would like to hear what are those challenges that you've been talking about, Toby.
I think it's to do with updating and bringing new data sets in and bringing search results in. So there are issues with how easy that is to do. It's not proved so problematic necessarily with the convalescent plasma review, but I think certainly with the diagnostic test accuracy reviews, that team have used confidence, and though it's been a bit disruptive around references as well, which I think is probably a story for another time. But I think if you are to do it, Jamie, I would contact the confidence support team in advance, let them know about the type of review you want to do, and also get their guidance from them around things like data collection forms as well. It might be that over time the data that you want to collect changes as well, and that might be quite disruptive if you sort of set up a fixed approach up front that you then want to amend later.
Great, thanks Toby. So I think what I'll do is I'll save any other questions for later, and I'll move on to the next part of our webinar today. So so both Terry and Toby have already highlighted that there will be challenges when we're thinking about conducting living systematic reviews. So in the next half an hour, members of this complex review support unit will talk a little bit more about the potential issues with conducting living systematic review. So we have Alex Sutton, who's going to talk first, followed by Neil Hawkins, and then Yichao Sin will talk a little bit about our experience of adapting our complex review support unit network meta-analysis app to accommodate a potential living systematic review and network meta-analysis. So I'll hand over now to Alex.
Okay, could I have a nod, Olivia? Am I coming through?
Yes, you are, Alex.
Thank you. Okay, so I'm just going to probably touch on some of the things that have already been said, and also raise some new ones. I'm not thinking particularly about solving these, for the COVID pandemic. It's more, a little bit more blue sky thinking, I guess. So one thing I kind of want to raise is that I think we may have been moving towards these living systematic reviews for longer than we appreciate. In a sense, I'm old enough to remember when the Cochrane database came out on a diskette, and then the major technology shift to a CD-ROM, and then it went online. And I'm kind of thinking, well, then the next stage to kind of publishing on the internet directly is probably the next stage to that. And I see all this as a bit more of a continuation than an absolutely new idea or technology. I think there's a lot being said recently, not just for living systematic reviews, but about how technology can work for reviewers. And a lot of talks about automation of searching, data extraction, etc. And there's a very interesting paper I've cited there by Clark and CRSU and all, who talk about doing a systematic review in 2 weeks using tools. And it was certainly an interesting and educational read to me, thinking how far we've come recently. And I do want to flag that I think some of those technologies are probably valuable for things like surveillance and some of these time-consuming tasks that have been identified for living systematic reviews. The whole idea of digital publishing is in its infancy, and generally not just in systematic reviews, but tools are continuously improving. And I also want to highlight this possibility of doing things that you can't do in static paper reviews, and for instance incorporate some user interactivity, and we will hear a bit more about that later. And it would be nice to see some sort of infrastructure, I think, built around updating living systematic reviews. A kind of, if anyone's ever written a blog, I think 70% of blogs are written on WordPress. We need kind of a WordPress kind of format or technology for living systematic reviews to make the actual writing and updating of that writing as straightforward and as possible. And as I've already said, I see some of this being a natural evolution of what the Cochrane database of systematic reviews has been at for nearly 20 years or more than 20 years now. And just want to flag another thing that I've been heavily involved in, which is to think about how things like some of the analysis methods also may be ripe to be used within living systematic reviews. One of the big developments in the last 20 years in meta-analysis is the use of network meta-analysis, because it seeks to consider usually all the treatment options with the aim of identifying the best treatment. And this goes back to something Terry said, can these things live and can the questions change? And I kind of see the potential for having sort of living network meta-analysis as being a very realistic thing, whereas new interventions are developed, they can be added, and we have very general questions for these living reviews, like what is the best treatment for condition X? This takes a very long-term view, of course, of what's seen, and we'll pick up again on another point, which is that maybe when individual patient data could be valuable for getting further insights into these treatments, it would be useful if such groups could be, if you like, the guardians of data where it's available. I also don't want to see all this effort that's going in to be kind of thrown away or not used to its maximum. And I know very little about this, but I'm a little bit concerned about things becoming redundant, either because funding stops or changes of staffing or people's interests. And I think it may be a good idea to think about some of these things from the beginning and making things like the whole website open access, or at least in a place where others can take it over, so people that may want to start working on a review that's been living for a long time can take over with very little resource implications, then you don't have to start from scratch. Moving to a specific point, and this has been mentioned as well, that ongoing studies are, are the rule, not the exception. And when we're doing systematic reviewing, there's almost certainly going to be studies that could be important out there. And I think these are important to consider when writing a review at the moment in at least two areas. The first is obviously how will those studies impact on the results I'm telling you today based on the studies that are actually published. And the second point is how should we take into account these ongoing research when making recommendations for future research. So we're not asking for what will be coming in anyway. And I've not got much to say about B at the moment, but I just want to flag a little bit of work I did on a little while ago that may be of use to people doing living systematic reviews. So very briefly, we have on the left here, we have a typical forest plot for a pairwise meta-analysis. We're looking at exercise on relieving pain for people suffering with chronic back pain. And we have our pooled result here at the bottom, which is suggesting there is a benefit of exercise, but it's modest. Some people would like to see kind of an effect size of around -30, where others, when interviewed people who are suffering from the back pain, would say, yes, I'd like to see -20 before I'd consider kind of the hassle, the pain, the extra effort of doing back pain exercises. And we see that our confidence interval here is ruling out -30 already. We don't need any further evidence for that. But if people are interested in -20, the confidence interval crosses that, there's a chance that it is that beneficial or close to that beneficial. So if we knew further studies were out there, we can look at our current studies, and on the right here, I've just got two very similar plots. They're essentially funnel plots, if anyone knows about funnel plots for detecting publication bias. We're not talking about publication bias here, but it's essentially the same plot. What we have is sample size per group on the y-axis and the treatment effect. And we've plotted those studies that exist. And we have colored all the regions that other studies could exist or in on, depending on how big they are and the effect size they present. And there are three colors, but one of them isn't shown. And the color we really want to see, which is incidentally purple, but there's no purple, is that a new study could get us to say that it's definitely beneficial at -20. But no study that could be plotted in that region, so have an effect size of -40 or have 1,000 people in a group, even that study wouldn't get us to where we want to be. Studies in blue would actually suggest that we've got a significant result that would say isn't -20, and the red would keep us in doubt. So we can say with some certainty that the conclusions aren't going to suggest back pain can be relieved to -20 with one new study in the near future. And maybe tools like this and looking at these possibilities is something that's worth considering. And I think that's it for me. Okay, so I'm going to pass straight on to Neil, who's going to talk about some other statistical issues that should be considered when doing living systematic reviews.
Yes, thanks, Alex. I think this probably follows on hopefully quite nicely. Can I just check? Oops, wait a second, I need to press a button. Can everybody see my screen?
Yes, we can, Neil. Thanks.
Excellent. So I'm going to talk very briefly about what's been called sequential methods for meta-analysis or trial sequential methods. And really they follow, they're relevant to any discussion about living systematic reviews because we're addressing potential biases that might occur when we're regularly updating a review and where that review or the results of that review might impact the conduct of further trials. That's the key issue. And so Ant-Man in 1992 noted that meta-analysis can reduce research waste and improve outcomes for patients. And in some cases, they could lead to definitive or recommendations for treatment far before an individual RCT would show that. So they actually help get treatments used or used earlier and more effectively. And as Alex has pointed out, it can also be very useful in the opposite, and actually stopping us doing research which is not helpful.
Neil, you're not sharing your slides, you're only sharing PowerPoint. So we're not seeing the slides update, just the outline.
Is that better?
No, you might be sharing PowerPoint, not the slideshow, or you might not fire the chats.
Let me have another go. Share screen. Is that better?
No, you've got your desktop or somebody's desktop.
All right.
That's better.
Excellent, excellent. So this paper by Ant-Man in 1992, they pointed out that meta-analysis could help reduce research waste, improve outcomes for patients, and made the observation that in some cases, the treatments they were looking at, they looked at a bunch of different treatments. effective treatments were not recommended for more than a decade after a meta-analysis of RTs would have shown them to be effective, which is clearly not a good thing for patients. So moving onwards, "18 years later, we're now have a kind of a bounty, and now sometimes we may well have more meta-analyses and studies. So this is an example from a website called Epistemolonicus, and it's really nice to give you matrix of evidence for different problems. And in this particular one, there are 22 primary studies I've identified and at least 42 systematic reviews. So we've kind of swung the other direction. And one of the interesting things to note is, as these reviews go through time, the number of studies increases as they bring in more recent reviews. But also, individual reviews may vary in the studies they pick up because there may be differences in the study inclusion criteria, the precise nature of the question they answer, judgments they make about study quality. So there are lots of reviews occurring, and there may be multiple reviews on the same evidence base. It could give slightly different responses. So why might this be a problem? So this is a simulation of a set of repeated sequential meta-analyses, updated as new trials become available. So in the first set, there's only one trial, second set, 2 trials, third set, 3 trials, and so on. And for this particular quick simulation, there's no treatment effect, real treatment effect. Each trial adds 100 subjects per arm. And importantly, the red points denote false positives in this case because I know what the true answer is. And we get about the right number of false positives if we use a p-value of 0.05. We get about 5% just by chance coming up statistically significant, which we'd expect. And that number is the same at each update. So that's fine, that's not really a problem. The problem becomes if those meta-analyses then influence future conduct of trials. So for example, very simply we say, well, actually, if your meta-analyses become statistically significant, as Ant-Man would have it, we now know the treatments by that benchmark is useful, so we might adopt a treatment. And importantly, we might then stop doing trials. We might stop doing trials for 2 reasons. One, directly because having done the analysis, trialists might look at existing evidence, decide it's already conclusive, and thereby not do another trial. Or if doctors and patients have decided the evidence is conclusive, it might become very hard to do a further trial. So it's fairly easy to see how meta-analyses might influence trial conduct. And in this case, because we're stopping when we get results, we're stopping for spurious signals of activity in this case, because there is no real effect. And actually, our false positive rate, if we look at the point at which these meta-analyses stop, is 14. So even though we're quoting a p-value of 0.05, actually we're overestimating our confidence. And similarly, it's the same thing if we look at the confidence intervals. Only 86% of these confidence intervals include the true effect rather than 95% we would hope for. So the issue is that we're overestimating our confidence in the results, and we're also overestimating or potentially treatment effects because we stop when by chance we get the biggest differences or deviations from a true effect. So this is a problem. This is what people worry about. Now, it has to be said that the link between meta-analyses and conduct of future trials is not that simple. It's clearly not the case that if we get one systematic review which is statistically significant, we stop at that point. Partly because there may be different number of criteria we use to decide whether we're convinced of an effect. And also because actually trials may have been started before the other trials have completed. So it's kind of a lag. But it's reasonable to think there might be a relationship between the results of meta-analyses and decisions to conduct future trials. And people like Alex are trying to make this very, very explicit. Now, within an individual randomized trial, we worry a lot about this, so we carefully adjust our analyses to take account of any repeated efficacy analyses. We may use different adjustments for interim analyses, alpha spending functions, and things like that. or we may even go to the extreme where we have these sequential trials where we can analyse the trial after every patient has been recruited, and on average that will give us smaller trials, but sometimes it will end up with much bigger trials. So within the trial world, there's a lot of emphasis on this, but also they have a much easier job because they make the rules. They can decide what the rules are for stopping a trial and design their statistical analysis to take account of those rules for stopping. Meta-analyses, it's not quite as clear. But anyway, a number of corresponding approaches, related to those approaches we use in trials to adjust for multiple testing, to account for the sequential analysis, the sequential nature of meta-analyses. And these are two quite important papers by Brock and Julian Higgins. And basically they borrow from the ideas we use in trials to try and adjust meta-analyses for the fact that we are repeatedly looking at the set of trial data as it develops, and that the development of that set of trial data, the results of those meta-analyses might influence our decision to conduct future trials. And they've done some simulation work, and they show that if you don't adjust, your confidence intervals are much narrower than they should be, and under certain assumptions, the methods seem to work quite well in getting our confidence intervals back to what we'd like them to be. But at the moment, these methods, say something in Cochrane, are not recommended for routine use. And it's worth looking at the arguments why they were recommended and why not they were recommended, and also think whether we need to revisit, I guess, that discussion, given the fact we're now explicitly going into living systematic reviews and very deliberately updating. So the arguments for, I guess, are quite simple, that if we do not adjust for these multiple tests and the results of meta-analyses influence the conduct of future trials. And this isn't saying that it has to be a strict, if it's statistically significant, we stop, otherwise we carry on. As long as in some way the results of the meta-analysis are influencing future trials, we will have this risk of bias. And if this happens, our uncertainty in effect estimates will be underestimated, and treatment effects will tend to be overestimated. And the more often we look at our developing set of trial data, the worse this effect is. It's also worth noting there may be multiple meta-analyses that conducted as the evidence develops. These may not be all by the same author. They don't have to be by the same group. Just as long as there is a set of meta-analyses developing alongside the development of clinical trials, and this set, and any one of these meta-analyses might influence that further decision to run a trial, we have this problem. So in a way, your intention to do a living systematic review or not is probably not that relevant. What matters is if there is effectively a body of living systematic review that develops over time. I think this is an important decision for Cochrane because Cochrane guidance influences how others conduct their reviews. So it's important Cochrane think about this question from their own perspective, but also probably important they think about how it might impact other people's behaviour and conduct of their systematic reviews. And clearly, I think it's important, we cannot say that our reviews will not influence the development of future trials. There's a very explicit literature, but starting from Maarten saying that we should be looking at trials as a group in making both our clinical decisions and clearly by inference whether or not we need to do further trials. And as Alex was putting, it's not only a question about whether whether a trial is needed, but also whether it's futile, whether it can potentially give us a significant result one way or the other. So what are the arguments against it? Now, by and large, these are taken from the Cochrane panel recommendations, but not exclusively, and I was not part of the panel, did not speak for them in any way. So some of the arguments against the need to use these methods might be, well, actually, we don't need to, it's not really that big a problem. So meta-analyses may not be updated frequently enough to this be a real problem. It might be a theoretical concern, but the impact is in reality limited. Another argument is that meta-analyses should stand on their own, summarising current evidence. And here I am quoting from the panel. And that decisions should not be influenced by previous meta-analyses or plans for future updates. So we should look at each meta-analyses review in isolation. But I think that's just avoiding the problem. Clearly, there is a body of reviews, and these do develop alongside the literature, either explicitly in living reviews or just by the very nature of reviewing. There's also an argument that focus should be on estimation of effect and its uncertainty rather than statistical testing, p-values and rejection of the null hypothesis. But actually this issue affects both confidence intervals and p-values. So it affects, you know, as long as you're worried about uncertainty, this is something you might want, you need to worry about. The final argument, another argument is, well, actually, we'll only recommend that meta-analysis is no longer needed when the results are so convincing of benefit or harm, and when further data are unlikely to change conclusions. And that by ensuring that we only make conclusions when we have overwhelming data, and we don't try and make conclusions on small amounts of evidence, this avoids this early stopping issue, which these methods address, so that they're not needed. Another concern is that actually the other side of the coin, that if we adjust our analyses based on these methods and they're not accurate, we may be increasing our false negative rate. We may be rejecting treatments which are useful. Another set of arguments I've summarized as the we cannot do it type arguments. One, and this is true, is that the meta-analysis himself has no control over the design of trials. Therefore, it's not possible to construct a set of stopping rules and design a sequential program that totally maintains the properties of these estimators. We don't know precisely how our reviews are going to affect the decision to do a future trial. We don't know if it's going to be based on a p-value or some function of effect size and so on. And because we don't know exactly what the effect of our analyses is on the conduct of future trials, we can't accurately adjust for that. So it's just too difficult. And alongside that, the argument that meta-analyses do not relate to a single question or decision maker. So sequential adjustment does not capture the complexity of this decision-making process. Both of which are clearly true. There's some argument that these methods do not work well in presence of heterogeneity when we have random effects, and simply they're just very complicated and more difficult and are not really necessary or practical. So kind of very briefly, there are the arguments kind of for and against. But I think the questions we have now, especially when we think about living systematic reviews, is the first question we should ask: do we think there is a problem with the estimates we're obtaining from our repeated meta-analysis? Is there a problem we need to address? And probably the crux of that, do we think our meta-analyses are affecting these decisions to do future trials in the way that causes a problem? We might then want to ask ourselves, what does this mean particularly for living systematic reviews? I think finally we then need to ask ourselves, do these methods need to be perfect to be useful? I think clearly we can't define perfect methods because we don't know exactly what the link is between our reviews and that decision to do future trials. But that doesn't necessarily mean we shouldn't be using them. They might still be better than not making the adjustment. They might be in some way even conservative. So I think the question we need to ask ourselves is, are they a useful second best approach, which even though they're not perfect, they still might be better than the alternative, which is not trying to make any adjustment before and just hoping that decision makers can somehow account for this potential source of bias. So that's the end of my presentation. Hopefully, I think we're gathering questions at the end. So I just need to stop sharing. This worked much better in the practice. So thank you very much, and I'll hand over to the next speaker.
Right. Can you see my screen okay?
Yeah, that's good.
Yes.
Did much better than I did each hour.
Thanks, Neil. Hello, everybody. My name is Lasserson. I'm a member of CRSU based at University of Glasgow. So recently, I have put a lot of thoughts and discussions on the topic of living systematic review. One reason for this is that we have been working on an app which contains weekly updated, so living evidence of pharmacological treatment for COVID-19. And that is this MetaInsight COVID-19 app. So as it is shown here on the screen, it is a tool for exploration, reanalysis, sensitivity analysis, and interrogation of data from living systematic reviews. So just a little bit background, this idea came to us when COVID articles were everywhere in the headlines earlier this year. on the systematic review registry Prospero, we saw huge amount of systematic reviews and COVID treatment registered. We found a lot of these are actually duplicated as they're essentially doing synthesis using the same pool of data. So the difference between most of these protocols is essentially drawing varied subgroups from the pool to suit specific research questions. So we think many of these efforts actually could be potentially avoided if we could establish an interactive web-based platform incorporating all the data and keeping them up to date, so that in this way people can freely select the subset that they're interested in to combine together themselves. So this is why we created this app. So this MetaInsight app is essentially a case-specific version of our MetaInsight app. So if you have not heard of a MetaInsight app, simply speaking, it is a free app that allows users to conduct network meta-analysis with their own data without the need of any statistical software. I'm not going to talk too much about it, as I believe a lot of you probably have either used or heard of it, but Maarten will put a link in the chat box and you can check it out. So this COVID app was built based on the MetaInsight, and the evidence for this COVID app was extracted from the living mapping and living systematic review of COVID-19 studies project website. So just want to say a little bit more about this fantastic project. So this project is a huge collaboration effort led by Cochrane, France, and colleagues worldwide. They did tremendous work to search, screen, extract, and appraise the COVID-19 studies. And they also do meta-analysis themselves and put the results on their website. So this is a very, very important and well-delivered project, and continuously well-delivered project. So just to be clear that we are not directly involved with this living systematic review, but what we created is a living analysis platform which allows everyone to be able to use their own judgment to conduct analysis. So now let me just briefly show you this app. See if these links will open. Okay, here we go. So this is what this app looks like. Just give it a second, let the data to load. Okay, here we go. So you can select the outcome of interest, and then the data for the selected outcome should be loaded in real time. Here we present the study there we go. Here we present the study characteristics in this table, and then the network they formed, and the network meta-analysis results is shown at the bottom. So at the moment, it shows the overall network and the results. But as you can see from the characteristics table, that there are a lot of heterogeneities between those studies. So different people may have different views how to combine those studies together. So with this app, it's very easy to do that. You can use the filtering options, or you can just simply select the rows from the studies, and then the network will be shown in real time, and also the results will be shown in real time. So, and also if you want to do further analysis, then you go to the detailed data analysis page where the users can access the majority of functionalities of our main MetaInsight app. So this is a very, very quick demo of the app. Please feel free to take a look yourself if you're interested. So next, I just want to talk a little bit more details on the automation aspect of this app in terms of data updates, as this might be interesting to those who is into the efficiency aspects of living systematic reviews. So as I mentioned before, the data in this app come from the living mapping and systematic review of COVID studies project website. This project continuously adds new data as they become available, and this data presented in forest plots like this. So manually extracting data from this forest plot is very time consuming, so we desperately need automations. We're very lucky that we have the help from another colleague, Jay, who is a software engineer. So what he did is he wrote a Python script for us, which can automatically detect and most importantly highlight any changes on this forest plot. So that has significantly saved our effort and time checking through the pages as far as plot on the website. But I'm aware that this automation aspect is quite unique to us because we can't get the living data directly. So we have to catch the information from the plot ourselves. But I just want to highlight and emphasize through this example that automation is very powerful and resource saving. And you can use it in many ways to help increase the efficiency of your review. So, okay, so in summary, there are a lot of decisions that need to be made in evidence synthesis, and one of them is which study should be combined into the analysis and which not. So what we are trying to do is to empower users to have that decision freedom and explore the data with assumptions that they themselves deem to be appropriate. And this is related to living systematic reviews because one concern is that authoritative reviews will be limited to a small number of authorship groups, limiting scientific disclosure. So this app provides an open platform for people to freely explore themselves. So this is in line with the spirit of open science, which I believe will be mentioned later. And then going forward, we think this could be a test case for an interactive reporting format for any network meta-analysis to increase the transparency of analysis and also facilitate data interrogation. Okay, thank you very much. So that's all from me.
Thank you, Yichao. So in the interest of time, I will just move on to our next speaker. So I must apologize in advance that we look like we might be running a little bit over time. So if you can stick with us, please do stay till 3:30. If not, then this webinar recording will be on our website and the slides as well. So our next speaker is Maarten van Smeden. Maarten is Associate Professor of Epidemiologic Methods from Utrecht University. Many of you may have already seen the paper by Maarten and his colleagues in the British Medical Journal earlier this year, the living systematic review of prediction models for diagnosis and prognosis of COVID-19. So I think Maarten's going to share with us the highs and the lows and also his thoughts on where living systematic review will fit in the whole evidence ecosystem now and in the future. So Maarten, I'll hand over to you.
Thank you very much. You can see my screen, I hope?
Yes.
All right. So again, thank you for this, for a nice introduction and for the invitation. It's very interesting because I think I'm the least experienced here in systematic reviews, and I didn't know about living reviews at all half a year ago. I'm not a member of Cochrane. I don't consider myself an expert even in reviews, but I do know, I think, one or two things about the topic of our review that we did, and I'm gonna into what I think is the future for living systematic reviews. So this is the paper that was published in the British Medical Journal in April, back in April. Was led by me and Laura Wijnands, and it's a systematic review of prediction models for diagnosis and prognosis related to COVID-19. We were interested in finding models that did something with prognosis or diagnosis or something about risk in the general population for being admitted to a hospital. And it's a bit of a weird review probably for most of you. First of all, it's about diagnosis and prognosis models, so not intervention studies, and we also did not conduct a meta-analysis. Also, I think interesting to note is that this was never set up as a living review. It was set up as a single systematic review just done rapidly. And I think we succeeded quite well with doing this rapidly. So this was a tweet that started actually the systematic review and was on the 13th of March. That's when we started our review. And Actually, we got our acceptance letter from the British Medical Journal. So after doing all the review work, getting peer review back and acceptance just 18 days later. So it's quite quick, probably. So how did we do this so quickly? Well, we had 14 prediction modeling experts ready to go. We had guidance by the Cochrane prognosis methods group, people that were involved in the systematic review. And of course, there was a high sense of urgency. We just started our lockdown, and we could dedicate our time, at least Laura Wijnands and I, could dedicate our full-time evenings and weekends to getting this review done quickly. And we all had, fortunately, experience with the tripod and the risk of bias tools that we needed to do this review quickly. And we even had a data extraction template available at the time. So we started in March 13. We screened 1900 titles, and we submitted our paper, I think, on the 23rd or the 24th, and we immediately started updating. We found an additional 700 papers. So while we waited for peer review, we did an update, and we told the BMJ. And actually, this is where the living review sort of originated from. It was a comment from the British Medical Journal editor saying that we might explore the possibility of periodic updates, in other words, to proceed with this as a living review. So from our 18-day sprint, it's changed to a sort of an endurance race. And I think also in that sense, we're pretty successful. We're already working on our third update. So this was published in April 7, the flow diagram. And so you can see that we included approximately 27 studies in April. Then we had an update in June 1, and we reviewed 51 studies. And we're now currently at the July 22nd as the last publication date in the British Medical Journal, with 107 studies and 145 models evaluated. And well, at least for a statistician as I am, these are good numbers. We already had 350 citations, 150,000 access picked up by media, and we currently don't have an update, but it's all relative. Of course, there's another more new living review about treatments. Of course, that has a bigger alt metric, is more talked about. But still, for us, for my reference point, this is quite successful so far. Perhaps you've seen this. The British Medical Journal has issued an editorial saying that they want more of this kind of living reviews. Also talking about the Cochrane collaboration and Annals of Internal Medicine working on it. And the final sentence is interesting, I guess. We will consider living systematic reviews in the dynamic research areas, and we are willing to learn as we go. Because I think we're at that point that we still need to learn how to do this in a proper way. So I also have a lot of more questions actually than answers. But one of the reasons for continuing or actually starting this living review is, of course, the evidence that is accumulating in COVID-19 publication land. And I have to give a huge shout out to ISPM Bern, who have an excellent website that helped us with our review. You can easily find COVID-related articles, and we're currently, according to their data, at 68,000 COVID articles. So one of the reasons, of course, to continue the living review is that we were afraid that we would be irrelevant very quickly because of the new models that would come to the literature. And also one of the reasons for doing this is that we had the opportunity to work with a really experienced, excellent and dedicated team. We started with 14 and it has now grown to 40, which has been absolutely very important for continuing. Without this size of a research group, we wouldn't have been able to do it. And we still continue because we don't have, at least that's our view, we don't have saturation yet. So we have looked at 145 prediction models, and unfortunately we all evaluate them at a high risk of bias. And another reason to continue on working on this research is because we also use this living review as an information source for what we call the COVID precise IPDMA consortium, where we're going to validate many of these models. Now this may be a bit, maybe we shouldn't, because if you look at Prospero, you can find more than 2,000 registered reviews already. So probably if we stop, somebody else will pick up. So good to highlight two of the major things sort of complete with a living systematic review. And the first thing has been touched upon already is the part of the reward. Of course, doing this, getting in a BMJ is very nice for junior researchers and senior researchers. But after that, after the first paper is published, there's no new publication reward every time you update the paper. Well, there is the time investment. And for us personally, we have no funding, so we do it all without funding in our own time, so to say. And so we rely heavily on the intrinsic motivation of reviewers, and this is probably easy to do for COVID, but probably a bit more difficult in other research fields. And I want to point out that the updates, at least from my point of view, remain a very large time investment, a surprising large time investment. Because every time we have to reevaluate the total evidence, we don't only update tables and figures, but we're rewriting large pieces of text. And even we now have to consider changing the methods of presentation, because we went from 30 studies to 200 studies, and you probably want a different way of showing those results. Other challenges are, well, it's very, I'm surprised actually that we got so many people enthusiastic for committing to a project that has no end date yet. Another thing that we're still trying to figure out how to work with is, how do you work with a dynamic pool of reviewers and contributors that start and stop? And how do you deal with authorship on the British Medical Journal paper? And how do you handle 40 authors that want to comment on an updated paper, a paper that has to be updated every, well, 6 weeks or 8 weeks? And we have been very beneficial with the editorial process at British Medical Journal, but of course they have a lot of, this is very challenging for them as well. So some reflection on living systematic reviews when there's not a pandemic. So for many research topics, I think keeping evidence synthesis up to date with a dynamic team of experts is excellent. But I think we do have to think carefully about these incentives, especially for junior researchers, if you don't have the pandemic urgency, especially if you don't have the pandemic urgency. And I think it's important to have scheduled periodic updates and setting an end date. I think we should do that too. And of course, you have to think about this pool of reviewers. Where do you get those experts, and how do you keep them? So one thing that, of course, surprises me, and I think if you've done any review, I think this is well, what we should end with always as a recommendation. Please, people, start using these reporting guidelines. In our review, we found inadequate description of the study populations, unclear intended use of the prediction models, model performance inadequately assessed and reported. It was really a big mess, which could have been probably largely avoided by just sticking to the reporting guidelines. So my last slide, some points for discussion maybe later. we have to think probably about how to change this incentive system for living systematic reviews, for contributors, for reviewers, for journals. And another thing that I'm thinking about lately is aren't we risking giving too much power to a small group of those people involved in a living systematic review? Of course, the bigger question is, what is the incremental value of living systematic reviews at all, especially in slower pacing research fields? So that was what I had to say. Thank you.
Thank you, Maarten. So before we go to our Q&A, I'm just going to ask Terry to spend just a few minutes to share with us some of the official mind maps that some of the members of the Complex Review Support Unit has done in terms of what our vision is for living systematic review as part of the evidence ecosystem in the future. Terry, over to you.
Thanks, Olivia. And just to double check, are you seeing Tony Hart?
Yes.
Yeah, great. Okay, so I'm mindful that we are running over time. This will be quick and hopefully a little bit of fun. When we have our teleconferences within NIHR CRSU, we often talk about the changing ecosystem that evidence synthesis sits within. And in preparation for this webinar, we're thinking about where living systematic reviews fits within all of that. And so Olivia tasked us with putting our thoughts on paper and creating mind maps of how we thought living systematic review fitted into that broader world of evidence synthesis. So we all did that independently. For those of you who aren't the same age as me, you won't recognize the picture here. This is Tony Hart, who was a children's television presenter in the UK. And he had a show where he invited people to submit their best art, and he would show each one and talk over it in a segment that he called The Gallery. So with apologies to Tony Hart and the Hart family, I'm going to offer you a gallery of some of the mind maps that we put together looking at living systematic review and the evidence ecosystem. So here's the first one. This one came from Annalise Sinnott from Cochrane, Australia. She took it from that seminal paper published in PLOS Medicine, where the idea of living systematic review is populated. And what you can see here are there are two circles. There's an inner circle that's systematic review as we know it. You have a research question, you have a review, and then hopefully that translates into some sort of guidance. But you can see that there are exits from the inner circle to something much bigger. And the exit points are the availability of data and changes in health practice. And you can see within this bigger circle, there's much more of an emphasis on things being living. And we're not just talking about living systematic reviews, we're talking about living guidance and maybe even living implementation of that within health practice. So here's the next one. This one is from one of our NIHR CRSU members, but we're keeping with that theme of things being circular, things being constantly updated. What we have here is we have three key aspects of evidence synthesis: how you design things, and you can see that that design is being influenced by the evidence that's available, and it is in turn influencing what the next studies look like. And that continues and continues, I guess, until there's an exit point. This rather messy one here, I have to admit, is from me. And what I've tried to do is split down the middle. On one side, we have how things work at the moment, and it's all a bit of a mess. You have various funders funding different studies, and none of them really speaking to each other, and no real coordination. You have various people working in evidence synthesis, performing systematic review, and again, there's no real coordination of that. Things can be collated as a network, as an overview, and the only thing that really links these together are the fact that they take a lot of manpower, and the end product is something that exists on paper, using the printing press that we've been using for hundreds or thousands of years. And all of that exists independently of guidelines. So there's really no coordination of these things. Over on the other side, I've got what I think the future could look like. And you can see it's much more linear and process-based. And there are lots of enablers on the other side here that could allow this to happen, using things like automation, core outcomes. And you can see that at each point, things look back to inform the start. And at two ends, I have two different things. I've included preclinical science because I think you can't divorce the preclinical science from the clinical science. And I've also included implementation science here. Here's another process diagram. This one's from Nicola and Alex. And you can see at this side, they have examples of what best practice is at the moment. They have examples of some of the resources that can be used. And the next step along, we have some of the themes that cut across evidence synthesis at the moment. And those are things like reducing research waste, data sharing. And then we have living systematic review really as a next step. And then they've explored some of the things that you could do with that. Things like interactive reporting, automation, and all of the things that could come of that. And then from Olivia here, we have something that maybe mixes those elements of process and a cycle. So we have the different aspects here of evidence synthesis, from the generation of that evidence to the questions that we want to be asked. And living systematic review fits very much within the middle of that, informing each step, but also being informed by each step. So you can see actually, although we did these things independently, there's lots of commonality around what we're thinking the future of evidence might look like. I'm going to finish with this one here. It's from that excellent COVID-19 project that you've already heard about. And you can see here they're very much taking a world view of this. But they're doing things in exactly the same way as we spoke about through the last 90 minutes, with living systematic review very much sitting in the middle of this, but that then informing not just research, but things like funders and policy and guidelines. So we're going to be putting all of these mind maps onto our website. If you've got ideas about what you think the future of evidence synthesis could look like, you can send us a mind map, and I'd be very happy for us to have a look at that and host that as well. So I'm going to stop talking there. I'm going to stop sharing, and we're going to open up for questions and comment.
Thank you, Terry. So I think, I know we've overrun, but it'll be good to just try and get a little bit of questions and comments in. I'm just going to kick off myself. So, the take-home message, I think for me, having heard everybody speaking today, is, there is a lot of value in living systematic reviews, and for Maarten's review is a good example, really impactful, really useful. But I also hear that it's really resource intensive, and you have to give a lot, and there's not always a way to reward that kind of effort. So then Toby talked about some sort of criteria for thinking about when we should be going to do a living systematic review, when the questions is important, when there are data coming up, and when we are not certain. But I'm still wondering, is there efficiencies in setting everything up as a potential living systematic review anyway? I mean, are some of the efforts, some of the resource intensity is because we're converting static reviews into living reviews. So in a sense, we have to go back in order to make this happen. Toby also talked about adaptive trial designs, and these trials are designed to be live, but it's to accommodate the changing practice and changing question. So I'm still wondering, is there an efficiency to actually us just investing in this? Should we all just be going for a living systematic review framework? So I'm looking at my panel. Maarten, may I come to you first?
I can try. So I guess from my perspective, I think we started from just a regular review starting point, and we transferred to this living systematic review. And I think we would have done things differently, absolutely. If we started with that, for example, thinking about how to present larger amounts of data. And of course, I'm in the fortunate position that I don't have to do meta-analysis. I think in the case of meta-analysis, it becomes much more important that you start thinking ahead. So in that sense, just talking from own experience, I think it would be good. But I'm curious what the rest of the panel members think about this, working with meta-analysis that are continuously updated.
Okay, Alex, I mean, you did talk about the the resource intensiveness of it. So what's your view on it?
Well, and again, this isn't original. I think this has come from discussions within the group. But maybe the word active is better than living. You can certainly have a review that somebody just does and never wants to see again, and that they do a good job of it, but they're not up for updating it. You have, for a lot of years, Cochrane have talked about updating and the models for updating anyway, and so I think most Cochrane reviews have a level of activity, and it's a sliding scale. And I think right at the extreme, you have what Maarten was talking about, which is absolutely days to do it and update it within days or certainly months. And I do think some sort of infrastructure that can deal with all that, and we don't just have 3 different modes for whether it's a journal or it's standard Cochrane or it's super fast kind of stuff. I don't see why we can't have one infrastructure and invest in that. It seems that a lot of people are reinventing the wheel at the moment, as we're very early in this process. I don't have the solutions, but I think some sort of core methods investment into getting other platforms right would mean that it could turn into any of the 3 and change at different times between the 3 as necessary. Toby talked about using some nous and some pragmatic sense here. We don't look at it every week if it really hasn't shown anything for the last 30 weeks. I agree with all that. Okay, Terry, I'm coming to you. What do you think?
Yeah, I mean, I think there definitely are efficiencies, and I mean, I'm an early adopter anyway, but I think technology can definitely help here, and that technology can be things like automation. There's also all of the crowd work that's happening within Cochrane. There's no reason that you can't crowdsource a lot of this for all the people that are learning about evidence synthesis as they go through their undergraduate degree or as they train. The other thing that I've been thinking about is people have been talking, and I'm going to answer your question by asking another question to people. So far, we've been talking about aggregate data, but actually, should we just get right down to the IPD? And would we have a lot of efficiencies if we could access the original data from each study? I see Neil's nodding. I don't know if he wants to.
I'm just picking up on that. You have a crazy process at the moment where we obviously collect data, we database it electronically, we analyze it, we print, we put it in a journal, then somebody has to search for that, print it off, re-extract the data in a very crude aggregate form and analyze it. I mean, as an idealist, what we'd really want to get to a world, picking up on the kind of open data type agenda, is where there's actually just a large data warehouse of trial data that you can then, people enter data into as it's collected, you analyze it. And also then we can address a lot of issues around network meta-analysis, where we have issues around differences between trials, understanding and accounting for those. So in a kind of utopian world, this would all end up in some place where we have huge distributed data warehouses, and that drives our synthesis of data. Whereas at the moment, we have this slightly bizarre process of analyzing it, reducing it to publications, trying with difficulty to find and extract it. But I suspect that might be some way off, but maybe this will be part of the process in helping push that agenda forward.
Okay, so I'm not really seeing many comments or questions from the attendees. I know it's been quite a long session and we have already overrun. So there is one question on whether this living systematic review framework could accommodate different types of review, including rapid reviews. So I guess the comments that were made earlier, we're talking about it would be great to have one framework for everything rather than, specific structure for specific reviews. Okay, so I think what I'm going to do is I'm going to close the webinar for today, and I want to thank all my speakers and also everybody who've come along to join us today. We are very interested in developing this work further, and I think that the world of living systematic review has only kind of just been reawoken since the 2014 paper. There is a lot of learning and a lot of opportunities. So if you're interested in conducting a living systematic review, or then if you need help, do get in touch with the CRSU. We will be looking to do more of these seminars in the future. So if you want more on living systematic reviews, then do let us know. And we will definitely plan more for future. So thank you again, and enjoy the rest of your afternoon. Bye, everyone.